1 minute and 42 seconds late. You may continue speaking for as long as you like. The next speaker, thank you. Oh, thank you. Thank goodness I have a colleague. Thank you. Who's the next speaker? I can't speak. I have to look at the program. Professor Monsieur le Docteur Waterloo, liberté, égalité, fraternité, and Anna, what is the fourth thing? Anna? No? Evgeny, what is the fourth thing? Liberté, fraternité, égalité, and number 4 is fromage frais. And after fromage frais, we have Dr. Antoine Waterloo, who has agreed to keep the time. Antoine, thank you.
Okay, thank you, Gilles, for your kind and energetic introduction. I will not speak about the freedom, but about the distal tubal pathology, which is maybe less entertaining, but anyway, we will see. First of all, we have to define the lesion of the tubes, and I think it is very important because there is a lot of mistake about that. We have to make a clear distinction between, if we speak about the distal lesion, between the phimosis and the hydrosalpinx. In the phimosis, we have still some passage, some patency of the tube, even it is very small. And in the case of hydrosalpinx, we have absolutely no passage, even if sometimes you may seem to have some fibroia. In fact, there is no relationship between the fibroia and the ampulla. That are hydrosalpinx. That is phimosis. If you deal with the phimosis, we will do fimbroioplasty. If we deal with hydrosalpinx, we will do neosalpingostomy. It means we are going to create a new ostium. Obviously, the prognosis is not the same between the fimbroioplasty and the neosalpingostomy. And then we have the structural tubal abnormalities. Already I said some word about that. And you see that we have the paratubal cyst. I show you accessory tube. And you have to make also distinction between the phimosis and the paratubal cyst. In this picture, that it is a big paratubal cyst. In this picture, it is a circulation which leads to a strict phimosis. So when you put the dye, you see immediately the difference. So hydrosalpingosis and AVF, we know that now for a lot of years that there is a deleterious effect of hydrosalpinx on IVF results. It is in fact very well known, and I just show you the work from Strondel. We demonstrated in 1999, but it was repeated after that, that if you do salpingectomy in case of hydrosalpinx, you will multiply by 2 the rate of pregnancy when you do IVF. That it is now a common knowledge, so people say we have to remove the tubes in case of hydrosalpinx. In fact, we consider today that salpingoneostomy instead of salpingectomy may produce comparable result to IVF if you do a careful selection and if you have some experience in this kind of surgery. First of all, the experience, you see this paper from United Kingdom in 1990, where in 2 non-specialist hospitals, they have only 5% of pregnancy rate out of 40 cases of hydrosalpinx. When they saw that, they said, obviously, we don't have to operate anymore the tubes, we just remove it in case of hydrosalpinx. Now, in the same country, if you see people like TCV, which is very experienced, we see that we have 34% of pregnancy rate. We have more or less the same in Lyon. It means that if you do a lot of salpingoneostomy, then you may expect to have at least 30 to 40% of pregnancy, which makes the things competitive with IVF. Then selection is critical. Of course, it is only an accurate selection. We make the things easy to decide what to do. When you have this case of hydrosalpinx in this neurosalpingography, of course, that it is something which is obvious. In this case, you are going to remove both tubes. You have no any expectancy to be able to treat this tube. What we have to be careful is that we cannot rely only on hysterosalpingography, because you know the meta-analysis from SWART. We demonstrate that we have between 20 to 40% of false negative and even 50% of false positive, which means that only endoscopy, and we already speak of that this morning, is able to answer. To decide, we may rely on some score, the tubal score, which is a score made about this one from Brussels. It is about the tubal mucosa, and you see that we have 5 stages. 1 or 2 are normal, with normal falls or distended falls. 3, 4, 5 are, more extensive lesions. And if you do a salpingoneostomy, you see that the result will be totally different between the stage 1 and 2 and the stage 3 and 5, which means that clearly, if you have a tube with the 1 and 2 tubal mucosa, you can make a salpingoneostomy. All the other patients with the 3 to 5 stages are to be referred directly to IVF because the results, as you can expect, are not good enough. So if you decide to treat the patients, what we have to do? First of all, we have to rely on the microsurgical principles as we did in the past. They are not new because Winston makes the description of that in 1977, so you see 30 years ago. What he said, we need a good magnification, a good light, respect of the tube, the no-touch technique, meticulous hemostasis, avoidance of peritoneal desiccation, acute adhesiolysis, use of fine microsurgical instrumentation and of microsuture. And today, laparoscopy provides both in a satisfactory manner. It means that in the past we did that by laparotomy with a microscope. Now we are able to do that by laparoscopy. We have to do the not-touch technique. It means we have to use forceps without teeth, of course. And if possible, not touch the tube or the minimally, and try to touch other structures. We have to irrigate, to use microsuture. And if you make an eversion of the tube, I will show you that in a small video, it is much better to do a microsuturing, better than to rely on the laser eversion, which is the Flora effect, which is nice, but we create a ring of sclerosis, so it is not probably the best way to do it. So in case of fibroioplasty, you see that the technique is quite simple because already we have an opening of the tube, so you have just to usually make some incisions of the antimesial part of the tube, and then we have to maintain the eversion by some suturing. In case of hydrosalpinx, it is a little more difficult because we have to try to find the old osteum, and from that you have to open the tube, and then to make some eversion of the tube. And I will try to show you that more clearly in a video, which is better. This is the fertiloscopy. But you have seen that, so let me take further. Okay, so usually we have to start, if it starts, it should start. With the visualization, I don't know what happens. I don't want to bore you. Okay, so we start with adhesiolysis. In this case, you are using the plasma. Plasma is more or less like a laser, but you can perfectly do that with the scissors and the bipolar cauterization. What it is important is to try to avoid what I do at the beginning, to do this kind of lesions on the tube, because on the uterus, because then you may have, some recurrence of adhesion, so we have to try to be very precise and to remove the tube. When you have extensive adhesion, like in this case, it is good not only to cut it, but to remove it, because if you just cut the adhesions, then we have quite a big risk of recurrence, and then in this case, it is recommended to make a total resection of these adhesions, which is usually not too difficult to do. Now we are going to hydrosalpinx, so we have to try to find the old osteum, which is a very small opening, and from that, So we have previously made a dye test. We have to try to open the tube. And if you are going to do that on the fibrotic tissue, then you have no bleeding, like in this case. And immediately you see, when the case is good, that the tubal mucosa is going through, which means that if the mucosa looks like that, is probably a good tube. Another example, you see that the tube looks not very good, but when you open it, you see the fibroia looks quite healthy. At that time, you may do the salpingoscopy, and then we try to open the tube on the sclerotic tissue, like that. If you have any bleeding, it means that it's time to stop to open the tube. And then we have 2 stitches. In this case, it was a 5-0 suture. And you see that this eversion is made, that it is what we call the neostomy, the cuff neostomy, which is the best one because we have 2 kinds of neostomy. We have the racket form or the cuff salpingostomy, like in this case. And if you are able to do that, it means that the tube is in a good condition, and it is much better to use this kind of approach. And then you have to stitch the eversion. In this case, it was a 6-0 PDS. You can use either PDS or a Dexon. It is exactly the same. What it is important is to use fine suture. You have to make a small number of stitches. Usually we put between 3 to 4 stitches per tube. It is exactly the same technique as we use, in fact, in the past when we were using microsurgery of the tube. So the only thing is when the stitches are small, it is a little difficult to see, but you see that we have quite a good magnification, which is provided by the laparoscope. And then we have to fix your eversion. You see, what also you see very clearly is the burn tissue. You see the white piece on the tube. We are sometimes obliged to do this kind of coagulation, but we have really to avoid as much as possible to do this kind of cauterization because it gives some sclerotic tissue, which is not good. You see the end of the procedure. You see that the tube, the end result is not too bad. Then after that, we make the patency test again, and we have to wash in order to remove the blood. In case of salpingectomy, just to show you this salpingectomy, because sometimes we decide to remove the tube. In this case, it was a small hydrosalpine, very sclerotic. We use in this patient a very thin instrumentation. It is only a 3 mm instrumentation, just to show it was possible to do it. What it is important, because salpingectomy is, technique that everybody knows, but we have to stay really close to the tube, once again not to impair the vascularization of the ovary. Remember, we are dealing with infantile patients, and so we have to be sure when you do that we are not coagulating the ovarian vessels. If you stay really close like that, close to the tube, in fact you have no risk at all to impair the ovarian vessels. And then people usually ask, do we have to remove the interstitial part of the tube? No, in case of infertility it is not necessary. We are just to cut it here, because if you remove the interstitial part of the tube, then you are creating a scar on the uterus, which is not the best way to do it, and it is no way to do that. So you can cut it just like that. It is not really a problem. So it is the end of the procedure, and then in this case it was the tube was small. It was removed by the umbilicus. So what are the results of this kind of approach? That are our personal theory in Lyon. We have 2 periods: microsurgery and laparoscopy. You see, if you are dealing with phimosis, we may expect 50% of pregnancy rate with ectopic pregnancy of 2%. And more or less in the 2 theory, by microsurgery or laparoscopy, we have exactly the same result. Why? Because the tube is more or less normal. If you deal with hydrosalpinx, we see a big difference between the result in the first period and the second one. And in fact, this bias is only made by the selection. It means that in the first period until 1998, we were doing salpingoneostomy in almost all patients with hydrosalpinges. Of course, due to the very good result of IVF, we changed our attitude since that time. And if you see now what happens, you see that we may expect 48% of pregnancy rate. And you see that the number is very low, less important than it was, because of the selection. And you also see that the rate of ectopic pregnancy decreased from 8% to 3%, which is consistent with the selection. It means if you are dealing with good tubes, and if you are doing the proper job, then the risk of ectopic is less important. You can see other result, distal occlusion, you see more or less we have the same. Fimbrioplasty, neosalpingostomy, it was reported in 1999. So in conclusion, I will say that, first of all, laparoscopic fimbrioplasty, so in case of phimosis, once again, it is an easy technique. We have a very good pregnancy rate if you do the diagnostic, a good selection and acute technique with the principles that I tried to demonstrate. In case of neosalpingostomy, we have only to do that on selected cases, but if you select the case, then it is still a valid option. And after a clear information, I think that it is something which is important because we have to tell to the patient that if you open the tube, you may have a reobturation, which means that we will have then to remove the tubes. But it is sometimes something that we do quite often because if you tell to a patient we have to remove both tubes because you have hydrosalpinges, it is very distressful for the patient. And usually, I think in my experience, patients say, okay, I prefer first to have the tube opened, to try to open the tube, and if you have a failure, then I'm ready to come back to another laparoscopy to remove the tube. I think that it is something we have to decide with the patient with a clear information. Thank you very much. Yes, sometime.
Thank you very much for a brilliant presentation, and my question again from the fertility doctor. And you show us the excellent data about the pregnancy rate and live birth rate after your microsurgery, after laparoscopy. But I unfortunately don't know exactly where can I found the not so bad results from in high level of investigation. For example, randomized controlled trials and absolutely different data from reconstructive operation in the hydrosalpinx, for example. And we as a practice, in day-by-day practice, can see that after the reconstructive operation and microsurgical operation, neosalpingostomy in a group patient, mostly in advanced age, the big problem is recurrent hydrosalpinx during the stimulation cycle, and it lead to third or fourth laparoscopy inside in the IVF cycle or the after IVF cycle. And what do you think about the indication to provide this type of operation concerning to age of patient and the duration of infertility?
Yes, two things. First of all, I'm surprised when we say that we have recurrent during the IVF cycle, because if you do a proper salpingoneostomy, when you have the result, it means if the tube is open, it will remain open, except if we have any infection. But if not, it will remain open for life, I would say. And if you have to recurrence of hydrosalpinx, it will be very quick. After less than 3 months, it is closed again. Okay, so the first question. Then concerning the age, usually people say everywhere, when you have patients around 40, remove the tube, go directly to IVF. We have a totally different approach in our group because we have demonstrated that at the age of 40, IVF results are not that good, 40 or over 40. And if you do IUI, you have still some good pregnancy rate, which means that it is good to give to the patient the chance to become pregnant, either spontaneously or by IUI. Of course, if you want to do IVF, you can do IVF, but the patient will not lose her time if you just do laparoscopy to open the tube. I think so. It is a valid option. Once again, we have to do that with information, to discuss with the patient. And in our department, we have demonstrated that at the age of between 41 and 43, our pregnancy rate in IUI was still around 9%, and our pregnancy rate in IVF was 8%, something like that, similar. Which means that probably when you have elder patients, it is not bad if the tubes are good to give the option to become pregnant spontaneously. Obviously, if the tube is not good, you have to remove it. It is why, once again, selection is the key.
I would like to ask you, what is the duration after the laparoscopy and neosalpingostomy of pregnancy rate? I mean, what is the peak pregnancy rate? How many months after the correction of the tube you will say to the patient, okay, it doesn't work, go to IVF?
That is a very good question, because in fact we know that the peak of pregnancy is between 6 to 12 months. And it is quite difficult to tell to a patient we have to wait that time. It means that sometimes we are doing, in fact, we do neosalpingostomy, and patient after 3-4 months say, okay, I want to have IVF, and sometimes we do IVF, even if the tubes are open. But at least the tube is open, and maybe for our second pregnancy it will work. But that it is one of the problems when we deal with infertility. It is because in the past, when we do microsurgery, we say to the patient, we have to wait 1 year. It was the only option. The patient said, okay, I have to wait. Now she knows that he has other options. So.
Перш за все, дякую доповідачу за результати. Я представляю клініку, навпаки, реабілітації репродуктивної функції хірургічним шляхом. Ми тривалий час раніше використовували мікрохірургію і, повірте, були вагітності. Жінки до IVF теж вагітніли, тільки після мікрохірургічних втручань. Зараз, звичайно, кількість цих операцій скоротилася, ми теж користуємося вже скажімо, пластикою маткових труб лапароскопічним шляхом, але в мене таке технічне, тобто я підтримую вас в вашій роботі, але в мене питання кількість трубних вагітностей після реконструктивних операцій на маткових трубах. Можливо, є по там сальпінгостомія, неосальпінгостомія, фібріопластика або загальна кількість. Кількість трубних вагітностей.
Yes, I show you that it is, around 4% now when we do a selection. About 4% when we do this kind of selection. Before that, it was much higher. It was 8-9%. With fimbrioplasty, it is 2% because usually the tubal mucosa is healthy in case of phimosis. It is why you decrease the number of ectopies.
Thank you very much, Antoine. Vive la France. Now, Mr. Oja will speak to time. Thank you, Kamal. Please.
So there's a slight change in the topic we got. We got early pregnancy here, and what we will do, the slight change in the tack from fertility towards early pregnancy. And what I'm going to focus on is on expectant and medical management. So a little bit about my hospital here. So we run an early pregnancy unit. We were the first unit which started daycare early pregnancy management way back in 2000. And this is now being followed in many centers. And we see patients who are coming to the pregnancy unit. We do a high resolution transvaginal scan. Our junior doctors are trained and they will scan the patients when they arrive. And we will be picking up the ectopics by ultrasound. And then we'll be doing also a rapid assay of serum HCG and progesterone. So these patients, when they come up, we'll be looking at early detection of ectopic pregnancy in asymptomatic women. That's the group we are looking at today. Okay? So I'm not going to the ones that we do surgery in asymptomatic women. And the aim is that we do conservative management strategy. That means we do nothing or we give medical treatment. So this is the picture of the St. George's Hospital. It has changed a bit. I haven't taken the recent picture, this is quite old. We have got a helicopter pad now on top, so we are the referral trauma center. And the service in the NHS in the UK is patients are referred by general practitioners, and then they are seen by us in the hospital. Whereas the model we have created at St. George's, which is being followed in other places, is we do a walk-in service. If you're pregnant, if you're under 12 weeks, you can walk and come to the hospital and we'll see you without GP being referring you. We're open from morning 8:30 to 11, and we call it the acute gynecology unit. That means we look at any acute patient. So if anybody as a trainee wants to come and learn gynecology and scanning, that is where you'll come and work with us. We'll welcome you if you're interested. So, the patients coming in, almost 90% are intrauterine pregnancies. And you can see 10% fall in the category of either ectopic pregnancy or the word PUL, which is pregnancy of unknown location. Okay? That is not a diagnosis, and I'll come to that in a minute. So at the moment, we are treating 70% surgically and 30% medically. And we give them either surgery in the end, those who are conservative, or methotrexate, or we're doing medical management. So what do we want to do? We want to decrease the surgical cases and increase the conservative treatment. That's the aim. So we're going to put into 4 categories here, and I'll skip this one. So let's look at the diagnosis. This is what your unit should be. It should be picking up ectopics by ultrasound in 87 to 93%. And that is the level of scanning you should have. Then only you can manage the early pregnancy unit for medical management or conservative. The diagnosis should be based on positive identification of an ectopic pregnancy. Okay? And that is the key point that you have to see to visualize it. And in most cases, you will see on a transvaginal scan an ectopic pregnancy. What I'm trying to emphasize here is that if you see a sac in the uterus and you haven't seen a fetus, you do not say this is pregnancy is fine. You say it's uncertain viability. When it's uncertain viability, that means you haven't got a diagnosis, which means you follow this patient up. I'm building up to the most important point, that when you say the pregnancy is not seen in the uterus and I can't see any pregnancy, I will say it's pregnancy of unknown location. What I'm trying to say is, this is the situation, it is not the diagnosis. And the reason why we say this is because if you call pregnancy of unknown location as a diagnosis, if you call unknown viability as a diagnosis, you're going to make a mistake. And that mistake could be very costly. So, Errors of these mistakes, so like you say pregnancy of unknown location, and then you leave the patient alone and you don't follow it up, may lead to a costly mistake. Maternal deaths have been reported in the triennial confidential inquiries in the UK, and I'm sure in many parts of the world this has happened. So it is important that if you're scanning, if you see a patient, just a sac, you need to follow this patient up to see there's viability, and they'll say this is a viable or a miscarriage. Same way for the pregnancy of unknown location. So if a trainee is working with us, and they are working in the initial part, we make sure that in the initial stages they take a second opinion. So if you're not sure in your practice, please take a second opinion. If you are unsure of the diagnosis, repeat the scan. I think it's important. And of course, before you give medical treatment like methotrexate, you make sure that it is not an intrauterine pregnancy or not a viable intrauterine pregnancy, because otherwise you'll be doing harm than good. So this, if you stop listening from now, you've got the key points. Let's go to the approach here. So basically what we are saying is, if you use any type of medication, like say methotrexate, and you use it in the wrong way, you may be doing harm and you may be delaying the time they can try. So this graph tells us at what stages you get different situations. So you can see the early pregnancy, you got the ectopic pregnancy, you got the intrauterine pregnancy, and then you got the miscarriages. So they're all between the 32 days and the 49 days. So the early ones, where viability is not known, is very around 35, 38 days. And in the next week comes the intrauterine early pregnancy. The next week comes the ectopic pregnancy, and then the miscarriage. You can see, quickly you can say where you are, roughly. It gives you an idea of where you are. For those who are not aware of the rules that we follow, if you do one scan and you want to give a diagnosis for a failed pregnancy, the CRL should be 7 millimeter or more with no fetal heart. If you see one scan and do a gestational sac with no fetal pole, it should be 25 millimeter or more. And the reason is you may be performing a surgical procedure like a termination where actually the fetal heart may be found in the next scan. To me, the simple thing is I call them back a week later or 2 weeks later and then say, let's see what happens. If there is a miscarriage, if there is a sac, then you should be giving it 2 weeks. If you've got a yolk sac, then it should be 11 days. And if you've got a fetal pole, then it should be 1 week, if you want to follow the referral pattern. So let's go to the key points here. It should not be based on a single scan. The first scan, if you say 3UL, a pregnancy unknown location, you follow up the patient, and then, of course, your serial STG levels. Cases where we make mistakes have led to, or 6% of them may result in be an ectopic pregnancy. So you may be making a mistake, and that may lead to serious consequences. So I've emphasized this point. The last confidential inquiry talked about a fast scan. A fast scan is the patient has come to A&E, accident and emergency. You do a quick scan to assess viability, and at that point you make your decision. That may lead to reduction of maternal deaths. 8 women in the last 3 years in the UK with the best facilities passed away because of ectopic pregnancy and failed diagnosis. So it's so important. The numbers are small, but they have huge relevance. Okay, so most of you all know the risk factors for ectopic, pelvic infection, smoking, previous ectopic. ART is also included into that, forcefully put embryos, and then previous tubal surgery. The key points for diagnosis will be seeing a gestational sac with a yolk sac with the fetal heart, that's a viable ectopic pregnancy. You can see without a fetal heart a non-viable pregnancy. It could be an adnexal mass with a little hypoechoic area called the vagal sign, or it could be just a blob, just a homogeneous mass on the outside the ovary, in the appendix. So here you can see one with the fetal heart. You can see the ovary clearly, and then you can see the sac with the fetal heart there. And here you can see again the bagel sign, where there's a little hypoechoic area, and then there's just a blob sign. So these are patients we have picked up with scan. Once you have picked up the diagnosis of ectopic pregnancy by seeing the mass, then you're going towards management. So it could be expectant, wait and see, or it could be medical management, either systemic or local methotrexate. So how do you select who should have expectant management? So it could be a patient who is asymptomatic, stable, compliant, she listens to what you say, she'll come back for follow-up, and of course you have out-of-hours emergency backup. You can see them, in case they come with pain and bleeding, you can quickly operate on them. And of course the HCG levels are very important, and there are no signs of tubal rupture or acute bleeding, and the ectopic mass is less than 4 centimeters. There are several studies that have shown the expectant management has been very useful. And if you go towards the levels of beta HCG, you can see the success rate from different groups, less than 200, 2,000, 1,000. It depends upon the progesterone, which may help you to guide whether pregnancy is failing. Because if you've got a low progesterone level, then it helps you to say, although the beta HCG is high, this is a failing ectopic pregnancy, and it may resolve by itself. Like failing a miscarriage, this is an ectopic miscarriage. Let's go to the medical management. The medical management, we've got methotrexate as one of the doses, as a treatment. And the criteria are similar. And the one that we use is methotrexate. The dose we give is 50 milligrams per square meter. It's calculated by our pharmacy. We give them the weight and the height of the patient, and then they give us the dose. We do a full blood count, UNEs, LFTs, repeat the HCG in day 4 and day 7. Sometimes on day 4 there may be a slight rise. But if the drop is more than 15% by a week and she's asymptomatic, then we don't need to repeat the dose. If their drop is less than 15%, they tend to need another second dose. Again, the criteria is asymptomatic, cutoff level, fetal cardiac activity. If there's a fetal heart there, then we tend to go towards surgery because it don't resolve well. If there's hemoperitoneum, then we go towards surgery. So, most of the groups are now using single-dose methotrexate. And I'll come to what we are doing a little later. The predictors of success, again, are HCG, the progesterone level, and the transvaginal findings. So, I'll come to now pregnancies which are outside the tube. And one of them will be cervical ectopic pregnancy. So cervical ectopic pregnancy, that if there is a fetal heart, then we transvaginally scan just like we do egg collections, put KCL into the fetal heart, stop the heartbeat, and then give them methotrexate. I tend to drain the amniotic fluid or sac fluid first, and then we give them the methotrexate. The earlier you pick up, the better. If they are larger than 10, 12 weeks, then you may have to do a hysteroscopy sometimes and then tie a suture about to stop the bleeding. Rare, but it comes. And the other one that is becoming quite common is cesarean scar pregnancies. Again, we monitor them conservatively. We give them systemic methotrexate, not transvaginal, and they tend to respond better. But again, conservative treatment of not doing anything if the pregnancy is failing is probably the first line of approach. The other one that we worry about is the interstitial pregnancy, or the old terminology is corneal pregnancy, because operating them is a nightmare. So we pick them up early, and then we give them, we watch them conservatively, or we give systemic methotrexate. So these are the situations. So surgical ones, when you will not do medical treatment or conservative, when there's pain, and obviously if you scan and you see some blood over there, and obviously in laparoscopy you'll see this is ruptured. So I'll just quickly try to run through what we have done at St. George's. retrospective analysis, and we see about almost the pattern of management is same. I've touched that. We look at this slide. We see about 10,000, 11,000 women a year, and roughly the ectopic rate is around 2.8%. So about 300 women come with ectopic pregnancy, and you can see the wide range of patients with ectopics. But the main one is tubal ectopic, and that is around 288. We've got heterotopic, interstitial, cervical, and scar ectopics. And of course, the diagnosis again, we've got a very high diagnosis rate, again around about 90%, and the different types of cases we get are obvious here with the slide. So let's look at the expectant management group. The expectant management group, there were 37 women who were fitting the criteria, and 22 of them responded well. And when they didn't respond, the beta ECG was not dropping, then we gave them methotrexate. And of that group, again, we had only 4 failures in the end. So you can see we did conservative, expectant, and then we added methotrexate onto that. So out of the 37, 4 of them ended up having surgery. And then comes the medical management. Again, we're giving them methotrexate right from the beginning. And what we have noted, of course, which I haven't presented here, the group 32 of them had succeeded, and 12 of them ended up with surgery. What we have seen recently in the last year, and the data is not here, is now we are giving less and less women methotrexate. So in the last 1 year of all the conservative treatments, we've given 1 patient methotrexate only, and the results are similar. So wait and see probably is a very good option for us. The criteria, if you look at here, you got, if your level of beta ECG is 430, then you have a better success rate. In the medical management, and it's 882 from the data we have. And of course, the progesterone low is an indicator that it's going to be more successful. So you can see again the level and the success rate with expectant management and with ACG with methotrexate. So in short, 28% of women in this study that we did retrospective were managed conservatively, and 82% were successful in the management of conservative treatment. Predictors were HCG and progesterone, and there was no relation between the timing of methotrexate administration and success rate. There is an argument of waiting for 48 hours to look at the trend in HCG levels before you give methotrexate. And that is what I'm saying, we're giving less and less methotrexate by just watching and observing. And it's a key point to note. So, I would say in selected patients, in the appropriate patients, conservative management could be useful, and it's an alternative to surgical procedures. Thank you.
Dear colleague, have you investigated the follow-up data about, I'm sorry.
Dear colleague, have you investigated the follow-up data about the rate of normal uterine pregnancies after methotrexate treatment of ectopic? Thank you.
They have been same compared to the normal expectant management and the surgical management. The ectopic rate is 5%, almost. You're talking about ectopic rate?
And normal intrauterine pregnancies.
It is similar. Similar.
Перш за все, дозвольте подякувати за безскучну доповідь. А питання в мене коротке. Через який період часу ви дозволяєте вагітніти після призначення консервативного лікування метотрексатом? Коли можна вагітніти після лікування метотрексатом? Після якого періоду часу?
At least there is a 3 months gap. At least 3 months.
А дані про побічну дію метотрексату В даній літературі таких вони трохи відрізняються, але я читав, що навіть і дорослим рекомендується не дозволяти, тому що є побічна дія, ембріотоксична, тератогенна дія, як ваші, може, є напрацювання. Тобто ви чітко 3 місяці дотримуєтеся, чи, можливо, є інші дані, можливо, трошки довше треба вичекати термін.
There is a lot of debate on that, and we have taken the option of 3 months to be safe. And we have also now moved towards not giving methotrexate. So we are decreasing the number of methotrexate.
Okay, thank you very much.
So in keeping with the excellent timekeeping, Professor Jay will answer more of the questions that you haven't asked yet. And he is highly motivated to accept the challenge to speak for less than 20 minutes. Jay, correct?
Yes.
Done. Yeah.
Okay, good morning, everyone. Good morning, everyone. First of all, I would like to thank the organizers, particularly Andrew and the entire team, for inviting me for speaking at this meeting. I would also like to thank Kamal Oja, who is a good friend of mine and an ultrasound guru, for nominating me along with the allied group of international speakers who are all stalwarts in their own field. So, Kamal has already introduced with regard to the ectopic pregnancy, the clinical factors, diagnosis and things. So I will try to focus only on the surgical management, although I have prepared the diagnosis which was excellently covered by Kamal previously. So I just wanted to reiterate that couple of things. One is the ultrasound is absolutely brilliant in terms of picking up ectopic pregnancy, and in fact, majority of time we will be able to rule out whether there is an intrauterine pregnancy or not. And the other thing that I wanted to reiterate is it causes significant morbidity, maternal morbidity, and in fact even in the UK with regard to quite an excellent National Health Service where the early pregnancy problems can be picked up at an early stage, still there has been about some maternal death. So it is important that we pick up ectopic pregnancies, and now with regard to the ectopic pregnancy, although most ectopic pregnancies that we see are the tubal ones, the cesarean scar ectopic has been increasing. And what I will do is I will focus on 3 key things. One is the tubal ectopic surgical management, then the cesarean scar ectopic, and the interstitial ectopic pregnancy. I will just leave this diagnosis part now. So now, straight on to the surgical management. We have already heard about the criteria for the medical management and the expected management, and Kamal has already alluded to the indications for surgical management. And this is a graph which is based on the national database of US, and as you can see here, the red one is the surgical management for ectopic pregnancy, and over the last couple of decades that's been steadily decreasing. And if you look at the medical management, it has been increasing. So I think we are becoming more and more brave, and as Kamal showed their own data, that becoming more brave in terms of managing expectantly, not even with the methotrexate. And now straight on to the surgical management, and I'm sure we all do laparoscopy now as a sort of a norm in terms of surgical management of ectopic pregnancy. The laparotomy, it's very rarely done, even in case of rupture ectopic, because we are all becoming more and more proficient in managing ectopic pregnancy laparoscopically. And there are certainly advantages, and there is a nice guideline. There is a guideline which is produced by our Royal College of Obstetricians and Gynecologists in the UK, and it is a brilliant piece of article which was published in BGOG in November 2016. And that has given a complete overview of the management of ectopic pregnancy, including expectant, medical, and surgical management. And there are clear advantages of using laparoscopy because it is a shorter operating time, less pain, earlier recovery, less adhesions, although there is no difference in terms of the pregnancy, subsequent pregnancies. And now when it comes to the laparoscopic management, what do we do? Whether it is a salpingectomy or a salpingostomy. And again, there are differences because the surgeon's preference, whether we are good at doing a salpingostomy procedures like Antoine spoke about, and depending on the patient history, and also how the pelvis looks like, and especially how the other tube looks like. And if you look at the US data, again, in the same article, they have looked at how the salpingostomy and salpingectomy. So here you can see the red one is a salpingectomy, and it has been steadily increasing, although it is very subtle increase. Possibly, and one of the explanations what the authors have said is maybe we are becoming less proficient in terms of conserving surgeries without having a significant harm. And possibly, maybe the data is coming up that even if you're doing a salpingectomy, that probably wouldn't compromise the reproductive outcome subsequently. And the Royal College guideline, I'm sorry for this, the small prints there, but in essential what they have said is, if the contralateral tube is normal, then the salpingectomy is preferred, but I'll show you the data for that. If the contralateral tube is abnormal, then it is best to perform salpingostomy. And one of the risks, if you are doing a salpingostomy or conserving tubal surgery, then we have to tell the couple or the patient that there is an increased risk of having a persistent trophoblastic tissue, and therefore they may need a methotrexate subsequently. So, just a technique which you've already seen from the experts on the tubal surgeries before. So first of all, we need to absolutely identify normal tube. And then the technique for removing the salping, the ectopic pregnancy with the tube, the key principle is you stay close to the tube. Antoine has already covered because it can compromise the vascularity and therefore the ovarian reserve. And then I think one thing that I always tell to our colleagues or trainees and things is basically it is best that we remove the tube as complete as possible. It is best not to leave any cornual stump. We have had quite a number of occasions where the cornual stump, they had ectopic pregnancy in the cornual stump. So that is something that we have to be absolutely clear when we are doing the surgery. With regard to the salpingostomy, it is where possible where the tube is almost intact. If it is ruptured, then it is quite difficult to conserve the tube. But once we stabilize the tube, then you make a cut with a monopolar diathermy or a bipolar, a needle, a longitudinal incision, and it is best to use a suction so that it causes a bit of hydrodissection, and then suck it out so that the whole pregnancy will come out, and hopefully there won't be much bleeding. And if it is there, then it is possibly best to diathermize with the suction irrigation and point diathermy to the bleeding points. What does the data says? And these are the data why the Royal College has come up with the guidelines. There are a couple of randomized controlled trials, and that has compared salpingectomy versus salpingostomy. There was no difference in terms of subsequent intrauterine pregnancy. And there are a number of controlled studies, but they are not randomized controlled trials. And they have shown that the subsequent intrauterine pregnancy is increased slightly. And if you're looking at the odds ratio here, it increases possibly about by 24%, the subsequent intrauterine pregnancy if you're doing a salpingostomy. But there is a risk of ectopic pregnancy, isn't it? That is what we always think about. And in those situations, there was no difference in terms of subsequent ectopic pregnancy in a randomized controlled trial, but based on the other cohort studies, it has shown there is a slightly increased risk of subsequent ectopic pregnancy. And if I'm taking one of the largest randomized controlled trial done, a multi-center trial done in Europe, and this, in this trial, they have compared salpingostomy versus salpingectomy in women who have got a contralateral normal tube, and they have followed up for about 3 years. And if you see here, the salpingectomy group, the cumulative pregnancy rate was about 56, and the other group was 60, so there was no statistically significant difference. And the median time to pregnancy is about 26 months in the salpingectomy group, and the other group was 20 months. one thing that they found a difference between the two groups was a persistent trophoblast, and that is what I mentioned to you earlier. But there was no difference in terms of repeat ectopic pregnancy. I think this is a very nice data, and the repeat ectopic pregnancy was salpingotomy was about 8%, and the other one was about 5%. So this is published in Lancet, and in the same Lancet paper, there was a commentary by experts from Belgium, and they have said, I think we need to look at it a little bit more detailed way, and we should involve the patients in terms of decision making. And they have even suggested, and in their practice as well, it is best to recommend salpingostomy if somebody who's more than 35 years, because obviously, as we know, as age advances, the ovarian reserve goes down and the fertility chances goes down. And obviously, with a history of infertility as well. So, what about if the other contralateral tube is abnormal? And again, this is a nice sort of a trial, although small numbers, where the fertility reducing factors is ectopic pregnancy or abdominal surgery or contralateral tubal damage, peritubal adhesions or previous pelvic inflammatory disease. And if you look here, the salpingotomy group with the fertility reducing factors, of course, women, intrauterine pregnancy, if you're performing salpingotomy, was about 75%. And in the other group was about 40%. And the ectopic pregnancy rates were similar. So this is again the basis of the Royal College guideline that if the contralateral tube is abnormal, or if there are any fertility reducing factors, it is best to consider a salpingotomy, a conservative approach. And with regard to the persistent trophoblast, yes, we need to follow them up if we are doing a salpingotomy, and in which case ask them to come back in about a week's time, do an HCG, and if the HCG is raised, then we'll have to either conservatively manage or methotrexate, depending on the clinical factors and the decision making. Now moving on to the cesarean scar ectopic, and we have seen again from Kamal about the diagnosis point of view, and I'm not touching on those sort of things. And we have the reported prevalence rate is about 1 in 1800 to 1 in 2000. I've seen about 5 or 6 cases in our last year, and we do delivery rates about 6,000. So I do concur with more or less a prevalence rate of about 1 in 1,000 to 1 in 1,500. And you can see here, just briefly, so you can see here the empty uterine cavity and empty cervical canal. So that is one criteria for cesarean scar ectopic. And you can see a cesarean scar, and usually the gestation sac is about triangle, a bit of triangle shape or oval shape. And if you do, can you see a sliding sign? So you do a sliding sign, because if it is a miscarriage, which is in the cervical canal, usually it will slide, because it's not attached. Whereas a cesarean scar, it is tightly attached, and therefore the sliding sign will be negative. And there are various surgical approach, and the evidence is there is no single surgical approach that we can recommend, and that is what the Royal College said. So I'm sorry for a busy slide, but just to tell you that there's a number of reports, probably about more than 200 cases have been reported. There's no sort of a large series with regard to this, and the 3 modalities that we use is, one is, as Kamal said, just a systemic methotrexate injection. But now we have moved a little away from it, unless we know that it is likely to be conservative, it can be conservatively managed. And one thing is an injection directly, so aspirating the gestational sac by doing a transvaginal aspiration and injecting methotrexate directly into the sac. And I'll show you a video of that. So here, so this is similar to doing an IVF procedure. So transvaginal scan and passing a needle and aspirating the gestational sac, and then injecting methotrexate directly, and then follow-up is more or less similar to what we do with the systemic methotrexate. And we have treated over the last couple of years, in fact the year before, we have been treating more or less almost all cases by this method. But however, we had a good success, as you see here. So this is day 0. Look at the beta HCG, it was quite high. And in fact, this fetus has had a positive fetal heart. And this is by day 7. It's almost gone, although the beta HCG has been slowly, gradually falling down. And at the time of about 6 weeks, it has been absolutely negative. we faced with one problem, that we did one case like this, and then what happened was, I think I've got the picture of that. What happened was the pregnancy sac has completely gone, sorry, the beta HCG has completely dropped down, but the pregnancy sac still remained, not the sac, the tissues still remained, and the vascularity has significantly improved. So when you're putting the Doppler on, each vessel was looking like, you know, my tip of my finger. So it's dilated about 1 centimeter. It was a bit scary. Just in case if a patient bleeds, she can bleed to death, probably in a short period of time. So I spoke to Davo Djokovic, you know, probably would have heard. He has done a lot of cases of cesarean scar ectopic, and he said we can do a surgical evacuation under ultrasound guidance. So the patient went to London, and I went with her as well, and we did the surgical evacuation. She lost about 2 liters of blood in about 2 minutes because the vessel was so dilated. And then couldn't completely remove the placental tissue, but although we removed as much as possible. And then thought of reviewing her in about 4 weeks' time. But in 3 weeks' time, she came to the A&E with a significant amount of bleeding. And the fact that she has had 3 cesarean sections before, 3 children before, therefore she was always begging for a hysterectomy. And therefore the decision was easy at that point in time. And this is how it looked. So this is at laparotomy. And you can see this is not the uterus, this is actually the uterus. And this is the ectopic. And you can see it is ballooned out and there is a lot of vascularity. And this is the hysterectomy was quite straightforward, no problems with it. So then we now, majority of time we do evacuation under ultrasound guidance. It is quite straightforward, and as I showed you here, if you look at this sac, the picture here, so generally we give 800 micrograms of misoprostol immediately pre-operatively, and that helps the uterus to contract. And then we apply a cervical stitch, so that's our routine cervical stitch to that, and it's basically that to give a tamponade below the cesarean scar and above the cesarean scar for the misoprostol to help with the sort of a tamponade. And then you can see here it is quite straightforward, generally the surgical evacuation, especially if you're doing it at an early stage, not with the vessels of 1 centimeter dilated and things. And you just go in with an ultrasound guided, and the first step is to empty the uterine cavity. Because so go beyond, so dilating the cervix probably up to 10 or just above the suction cannula, and then emptying the uterine cavity first, and then coming back, and then suck the pregnancy out. And as soon as the procedure is out, and as I said to you that putting the cerclage is just putting the stitch in, but not tying at that time. And then as soon as the procedure is completed, then tie the stitch. And that worked quite well. And then the follow-up is not that needed, a long-term follow-up is not needed. Cervical ectopic, Kamal has already gone through. There is no sort of hardbound evidence how we can manage. Surgically, the college recommends probably it is best to approach with a medical management because of significant risk of bleeding. Interstitial pregnancy, and the diagnosis again Kamal has alluded to, and one of the things is here, I mean this is a heterotopic coronal ectopic, and this is one area where we can use a 3D ultrasound because you can get a coronal plane and you can clearly see here that's a uterus and that's the interstitial pregnancy, and this is interstitial sign that is typical of a diagnosis of coronal ectopic, and you can see the myometrium all around. We are missing this part. But one diagnostic criteria on 3D ultrasound is if you can see the myometrium all around the pregnancy, that is more diagnosis of interstitial pregnancy. And in which case, when you're doing the procedure, yes, the surgical management is probably the right approach because if she bleeds, that can be quite catastrophic. The best thing is you start with the salpingectomy. So although the ectopic is here, it is best to start performing the salpingectomy from here, and then gradually go up, and then either you can use a bipolar. What we tend to do is using a loop, endo loop. So basically, when you're doing a salpingectomy right from the lateral aspect, and then you can put the endo loop a little bit more easy and tighten it, a couple of endo loops, so that hopefully will reduce the bleeding, and in fact, that secure the hemostasis soon after the procedure, and then excise the ectopic. So finally, to conclude, I've told you different types of ectopic pregnancies and different surgical management options. And with the tubal ectopic, salpingectomy was a salpingostomy. So if it is, the general guidance is if the contralateral tube is normal, salpingectomy. If the contralateral tube is abnormal or if they have got fertility reducing factors, then salpingostomy. Cesarean scar ectopic, surgical approach probably is preferable unless it is likely that we can manage conservatively. Cervical scar pregnancy, surgical, there is no sort of a clear evidence. This is all sort of based on case series and things, and the recommendation is a medical management. To begin with, interstitial pregnancy, surgical approach. Some people use a hysteroscopic approach, but that is if it is more towards the uterine side rather than more towards the tubal side. Corneal pregnancy, and this is what Kamal has previously said, because we always synonymize with corneal ectopic with the interstitial ectopic, but corneal pregnancy is basically if there is a rudimentary horn or a horn, then yes, and if there is a pregnancy, then surgical approach is probably the best way forward. Ovarian pregnancy, again, surgical approach. I haven't gone through, but it's mainly that partial excision of the ectopic with the ovary, with the possibly ovarian tissue around as well. Heterotopic pregnancy, I'm sure you all agree, it is very logic that it is best not to approach with a medical approach, therefore the surgery is the best approach. Thank you very much.
Для двох запитань. Одне запитання професор Кульчинська.
I want to ask a question of what is the cesarean section rate in Ukraine? Who knows? Evgeny, what is the cesarean section rate in Ukraine? He's asleep. Anna, what is it?
35.
35%.
No.
Thank you.
No.
Thank you. No. Thank you. One answer. Thank you. Next question is, how many colleagues have encountered cesarean section scar pregnancy? Hands up. No, you're not Ukraine. You stay there, Eric. Think about your pigs. 1, 2, now, please, hands up. No, keep them up. It's like Eurovision. 1, 2, 3, 4, 5, 6. Thank you. Right. So, is he correct about management or not? Hands up if he is correct. No, he's in. 1, 2, 3, 4. Anna, yes, Evgeny, still asleep. Thank you. We now must move on. Do you have a question? Thank you. Short, because I talk too much. Yeah, I talk too much. Short.
А чи бачив доповідач вагітність в розі матковому після видалення маткової труби, яка готувалася?
Sorry, I think this one didn't work.
Чи бачили ви випадки корональної вагітності після видалення маткової труби?
Have I seen any corneal repeat corneal ectopic? Yes. I have come across cases, and in fact, one lady who has had a corneal ectopic on one side, we managed conservatively, and she had a methotrexate, in fact, and then she came back with another corneal ectopic. We managed with a methotrexate, and then again a third ectopic for her. So then we did a surgical approach. Then obviously we went on with the IVF, and unfortunately, she had 5 cycles with 1 fresh cycle and 4 frozen cycles, and she didn't have any pregnancy yet. So I'm not sure whether there was any sort of an implantation problem. The endometrium is not receptive, but in fact she was fed up, and now she said she's drawn a line.
Did Professor Jay answer your question? Yes, no, don't know. Yes, thank you very much. Jay, thank you, wonderful. So now the next speaker is my, what is the Ukrainian word for angel? Andrew. What? Angel. Angel. So, Professor Marta Dernfeld is my angel. So I have a conflict of interest, and Professor Dernfeld, who is very eminent, will speak to you about this very important subject of recurrent implantation failure. And Marta, is that okay? Thank you. If you want to know why Professor is my angel, exactly.
You have followed the tube and
but the husband will come in the door any minute, Andre. Any minute. He will ring me. So now we are ready for Professor Denton.
Thank you very much I would like to thank the organizing committee to invite me to such a beautiful place and to give my lecture, which will not be directly on the fallopian tube, but I will touch it, as you will see. So I'm going to speak about repeated implantation, but I'm focused in IVF because there are several definitions. There is the definitions of recurrent pregnancy loss, repeated implantation failure, and failed in vitro fertilization. They could be considered absolutely different, and we could give a lecture on each of the topics. But in IVF, there is one thing common to all these three categories, which is that they are all age-related. And many IVF failures are age-related or poor responders. And a lot of people, they mix up the repeated failures with diagnostics and treatment approaches which are not adequate. For example, doing many tests on a 44-year-old woman that has failed implantation will probably not show thrombophilia or other problems, but it is age. The repeated implantation failure is because of the age. The ESRA consensus on the definition of poor responder is at least two of the following three features, which is one, advanced maternal age, a previous poor ovarian response, and an abnormal ovarian reserve test, anti-follicle counts, which is low, and AMH, which is low. And I'm going back to this famous graph, which was published by Sunkara et al., which shows that there is an association between the egg number and the live birth rate. And we know today that patients who have above 15 eggs in a certain IVF will have significantly higher pregnancy rates than a patient that has each time 1 or 2 eggs, and she is defined as repeated IVF failure. So the repeated implantation failure in IVF is related to fetal factors, to material factors, and to other factors. And I again want to stress the maternal age, which is associated with the egg quality and the poor ovarian response, but there are also environmental factors that are associated to the egg, which is smoking, alcohol, obesity, hormonal, and obviously genetics. And the protocol of stimulation and the monitoring, and sometimes she's young and she doesn't have all the above, and we don't know why she fails repeatedly in IVF cycles. Oh, sorry. So as to the fetal factors, the only techniques that I found that can improve theoretically, and it needs to be studied again, is the improved cell selection by IMSI. When we have repeated failures, it can be due to fetal factors, it can be due to the egg or to the sperm, and the selection of spermatozoa based on the analysis of morphology and the high magnification has been shown to improve pregnancy rate with sperm factor, male factor, and repeated implantation failure. There are many works that have been done, although few are prospective randomized, and obviously it should be individualized because of the cost of the procedure. The pregnancy outcome in women with repeated implantation failure after IMSI, there's only one prospective randomized study, but there are a lot of retrospective studies. And the randomized control studies, they analyzed 200 couples with 2 previous unsuccessful ICSI, and the 100 couples were submitted to ICSI again, and 100 couples were submitted to IMSI. And they found that the ongoing pregnancy with IMSI was 22% versus 13% with ICSI, live births 21 versus 12, and miscarriage rates 15 versus 32% in the ICSI. This prospective randomized study has not been repeated since then, but in many IVF centers, they use IMSI in an individualized approach. Assisted hatching is another way that there was considered to improve fetal factors. However, and we were using it for years, but now there is a review of the Cochrane database and other studies that have shown that there is no benefit for the assisted hatching in repeated implantation failure, and recently there has been also publications that it can even harm. What about PGS, pre-implantation genetic screening, is a huge subject. I cannot speak a lot about it. However, it has been indicated in repeated IVF, suggested in repeated IVF failures, but there are a lot of drawbacks. Any single cell analyzed may differ genetically from the other cell. There is a decreased pregnancy rate proven, and in PGS, the inner cell mass may be completely or mainly euploid, thus representing a false positive diagnosis. A position statement from the ESHA PGD Consortium Steering Committee published 11 prospective randomized studies doing PGS for advanced maternal age, and I told you that it is related to repeated IVF failures, and there was no benefit for PGS. So there's no evidence here that routine PGS is beneficial for patients with the advanced maternal age, and more details are needed. There now have been published a lot of data about advanced techniques in PGS, like broad-spaced clinical application are required to better define the role of NGS and whole gene amplification in PGS before recommending widespread application. As you can see, there are some publications about next generation sequencing and whole gene amplification. However, they call it now PGS2. PGS2 was discussed by 37 opinion leaders in June 2016, and still, even with the more advanced techniques, there is no consensus. What is PGS2? PGS2, the definition is biopsy at the blastocyst stage, followed by comprehensive chromosome screening and possibly combined with vitrification. But the why and how and when the PGS2 is not clear yet, because current practice and expert opinions of fertility specialists, molecular biologists, and embryologists is not yet in agreement to use it routinely. I'm going to the next device that can maybe affect repeated implantation failure by either improving the culture conditions or better selection of the embryos. As we know, poor morphology and abnormal cleavage is revealed through time lapse and could provide the basis of a qualitative algorithm for embryo selection. This technique is quite expensive, and for those women who have only 1 or 2 embryos, we might question. This would be also the poor responder. We might question if we can spend the money for the embryoscope because, each slide costs a lot of money. However, if it gives a better culture condition, maybe it is wise to use it. And then I'm going to another group of treatment proposed in repeated implantation failure, which is called adjuvant therapy. What is adjuvant therapy? Adjuvant therapy is an empiric or evidence-based medicine drug treatment or procedure that is not directly related to the routine treatment of a patient. So the interventions with drug are many because repeated implantation failure is very frustrating for the patient and very stressful for the doctors. So aspirin, many studies, no benefit. Glucocorticoids, if they are not indicated, many studies, but no positive. Growth hormone. Dehydroepiandrostenedione, I will speak about it in a minute. Viagra has not been proved as an effective way. We have the GCSF or ATG uterine injection, intrauterine injection, which is there are many more studies to be done, and there were some positive impact and negative impact, so that it is still questionable and we need more studies. The anticoagulants, when well indicated and sometimes even not indicated, have shown to give some benefit, and I'll touch it. IVIG is also questionable, still more studies are needed, and antibiotics has also been studied but has not been in a consensus. Recently there is also stem cell injection into the cavity, and a few days ago I heard a very nice lecture from Carlos Simon from Valencia, who is injecting bone marrow stem cells into the cavity with very, very promising results, because he took bone marrow from male and he found XY stem cells in the endometrium. So he claims that it is very, very promising. But I think that we will hear from you more about it. So I would like to present you a Cochrane studies about 17 RCTs in a total of 1,496 participants. And in women identified as poor responders undergoing ART, pre-treatment with DHEA or testosterone may be associated with improved live birth rates. I'm very skeptical about the DHEA story, but when I see such a report by Cochrane, I give some respect. Nevertheless, there is insufficient evidence about the safety of either androgen or isoandrogen. The definitive conclusion on the clinical use of androgen awaits evidence from well-designed studies. What about granulocyte colony stimulating factor? As I told you, it is not negative, but there are studies that show that it improved clinical pregnancy rate. And there is another study that was published recently in the International Journal of Reproductive Biomedicine that shows that it didn't improve pregnancy rate. So maybe it will be promising, but not yet. What about low molecular weight heparin? This is also a big debate, and for your lecture, I read again hundreds of articles. In women with more than 3 repeated implantation failure, the use of low molecular heparin significantly improved live birth rate by 79% compared with the control group. However, unfortunately, in this study, the number of patients was very, very low. And the calculation is that 8 women would require treatment to achieve 1 extra live birth. I mean, when there is no indication but repeated implantation failure. So adjunct low molecular weight heparin to improve live birth rate after recurrent implantation should be still considered in view of systematic review and other recent studies. However, we cannot prove that it is the first line of treatment. The IVIG is also an approach that has been suggested in repeated implantation failure with a lot of reports and controversy. There are 10 studies that included IVF patients with IVIG versus placebo, and they showed trend to higher implantation rate compared with the placebo. Clinical pregnancy rate and live birth rate were significantly increased in the IVIG group, and these studies strongly support the IVIG in women undergoing repeated IVF failure. But there are also studies that shows the contrary. And in view of the very, very expensive drug or approach or treatment, still IVIG is not the first line, unfortunately. What about antioxidants, vitamins E, vitamin C, vitamin D? They were all studied and were not associated with increased live births compared to placebo in repeated implantation failure. So we come back to the fallopian tubes. There are other interventions that should be considered, and they are simple and approachable and very effective, which is salpingectomy, hysteroscopy, endometrial biopsy, spherage injury, or whatever piping. So hydrotherapy, surgical treatment of tubal disease is very effective. There are 5 randomized studies, controlled trials involving 646 women that show that surgical treatment should be considered for all women with hydrotherapy prior to IVF treatment, and obviously in women with repeated IVF failure. There is still a debate whether to remove both tubes when you see only one before starting the IVF, because as it is mentioned here, it might reduce the ovarian response. And it doesn't eliminate, hydrotherapy doesn't eliminate the chances for a pregnancy. So I would suggest it for a woman only after repeated failures. What about the thin endometrium? There is a whole story about the thin endometrium. We all know that Asherman syndrome will reduce implantation. And the endometrial and genetic stem cells isolated from autologous adult stem cell could regenerate injured endometrium, which is not responding to conventional treatment. However, sometimes we have thin endometrium with no cavity abnormality, and Kamal and me and another in a group, we analyzed it in more than 700 egg donation cycles. And we demonstrated that when the endometrium was thin, but no Asherman and no intracavitary problems, the pregnancy rate didn't decline with thinner endometrium. We got pregnancy and live deliveries also at 5 and 4.5 millimeters if the cavitary problems were excluded. In patients with at least 2 failed IVF or ICSI attempts, a simple diagnostic or operative hysteroscopy before subsequent IVF ICSI is thought to improve reproductive outcome. And indeed, to a patient that comes to my clinic and she has repeated failed IVF, I advise her to go for a diagnostic hysteroscopy. Today, it is a very simple procedure with the alpha scope, and it gives in 20% findings that could be treated very simply. As you all know, hysteroscopy can solve a lot of simple problems and improve implantation. What about fibroid? We don't know exactly the impact of fibroid, but we still did another work in egg donation, egg recipients, and we saw that even fibroids that do not distort the cavity would cause a problem. I don't have a lot of time to speak at chronic endometritis, but it is emerging new diagnosis that has been emerged again now in the literature, and maybe we should study more the aspects of chronic endometritis. I don't have time to speak about the PIPEL. There is also a controversy, but it is a simple procedure with not a lot of side effects. So maybe it should be considered in view of many works and many studies that proved the procedure in repeated implantation failures. However, in our group of egg donation patients, the PIPEL didn't show repeated implantation failure improvement. Thank you very much.
Martha, thank you. 20 seconds for a question, so it has to be quick. And Professor Dirnfeld will answer questions at the end or at lunchtime. No questions? Perfect. Thank you, Martha. Our next speaker is Professor Irina. She is going to speak about the cutting edge of our science, about stem cells. She and I, we have been talking, and you didn't hear, we do this text, and what we have agreed is that you will have your lunch at 8 minutes past 1. And the reason it is late, it is your fault. You are asking too many good questions and challenging the speakers. Thank you, Professor.
Thank you very much. Шановні колеги, мені приємно виступити в такому шановному товаристві. І моя доповідь буде не про експериментальну, адювантну терапію, яка ніде не прописана в гайдлайнс, настановах і є експериментальною. Стовбурові клітини та імплантація. Ну, я би хотіла пару слів сказати про ендометрій, що ендометрій – це те, куди імплантується плідне яйце, і він має дуже велику роль, відіграє дуже велику роль. До речі, от той випадок, який професор розказував про позаматкову вагітність, яка постійно виникала в інтерстиціальна, в трубі, і після того, як видалили все, де вона може імплантуватись, в матці не наступила. Да? Тобто тут явно імплантаційні проблеми ендометріальні, скоріш за все, були причиною позаматкових цих. Ендометрій в кожному циклі виростає, тут картинки є, ви це все знаєте, від 4 мм до 7-14 мм всередині цикла в лютеїновій фазі. І ця товщина дуже потрібна. Ця товщина потрібна для того, щоб створити безпечне середовище для плода і для матки, для мами, тобто щоб дуже інвазивний хоріон не зруйнував орган, в якому плідне яйце знаходиться. І тому тонкий ендометрій може бути причиною неплідності, невдалих імплантацій, завмерлих вагітностей, викиднів і проростання, скажімо так, різних ступенів інвазії, аномальної інвазії плаценти. Як відновлюється ендометрій? В принципі, скажімо так, ми це ніби вчили, але кожна тканина в організмі має стовбурові клітини, тобто якийсь запас, який потрібен на випадок якоїсь небезпеки, на випадок руйнації тканини, для відновлення тканини. Ну і перше, ретельно описала стовбурові клітини ендометрія Керолін Гарджет, це австралійська вчена, і вона знайшла там в ендометрії мезенхімально подібні стовбурові клітини. І вважається зараз, що вони є оцим резервом, який дозволяє ендометрію відновлюватися. Не так в циклі, це більше і в циклі теж, а і після всіляких втручань, якогось ушкодження ендометріальної тканини. І зрозуміло, що у випадку, коли руйнується ніша, тобто ті місця, де знаходиться цей ендометрій, ці стовбурові клітини в ендометрії, або якщо зменшена їх кількість, або якась якість не така, то тоді ендометрій не може відновитися. Мезенхімальні стовбурові клітини взагалі є в багатьох органах, вони походять з строми і можуть диференціюватися у різні тканини, їх виділили з безлічі тканин, і їх використовують для такої тканинної інженерії, для регенерації тканин в різних клінічних практиках. У всіх випадках поки що, як правило, експериментально, тобто це не така базова, скажімо, терапія, але є в певних напрямках такі суттєві успіхи. Це обумовлено тим, що ці клітини утримуються, це дорослі стовбурові клітини, утримуються в органах в такому недиференційованому стані, а у випадку потреби, небезпеки, вони диференціюються. І вони поліпатентні, тобто вони можуть диференціюватися в в різні тканини, в кістки, в хрящ, в жир і в ендометрії. Чи впливає товщина ендометрію на результати імплантації, на імплантацію в допоміжних репродуктивних технологіях? Питання, але, власне, клінічно лікарі визначаються, практично всі приходять до думки, що низька товщина ендометрії, менше 7-6 мм, все-таки погіршує результати допоміжних репродуктивних технологій. Ну і є роботи, принаймні оця робота 2008 року, яка гарно показала, що частота настання вагітності при ендометрії 4-5 мм близько 9%, а більше 7 мм 51%. Тобто суттєва різниця є. І тому виникла логічна, на мій погляд, така ідея, що чому не взяти мезенхімальні стовбурові клітини в інших органах, де вони збереглись, і не перенести їх туди, де їх не вистачає. В нашому випадку це в ендометрії. І такі роботи були проведені на тваринах, і тут на пацюках показали, що введення це не отологічні, це у інших тварин брали кістковий мозок, виділяли звідти стовбурові клітини мезенхімальні і вводили в ендометрій. І було показано, що ендометр суттєво, товщина різна при введенні, в експериментальних тваринах руйнували ендометрій, і він відновлювався краще при введенні стовбурових клітин кісткового мозку. Ми також задумалися над цією проблемою і почали таку роботу. Спочатку у нас були експерименти, робота в лабораторії, потім ми це запропонували жінкам як безкоштовну таку терапію, повністю пояснили їм, що вона експериментальна і що ми не знаємо, які будуть результати, але пацієнти з невдалими імплантаціями багаторазовими, вони погоджуються на такі речі. Наша перша пацієнтка народила дитину у 2009, по-моєму, році. Ми там публікували тези, і в 2013-му написали таку повноцінну вже статтю в наш журнал «Здоров'я жінки». Намагались опублікуватися РБМ онлайн, але нам це не вдалося тоді. Не тільки ми цим займаємось, тобто зараз є дві таких публікації. Це перша, вона з Індії. Випадок описаний, коли у пацієнта з синдромом Ашермана використали так само стем-сел, стовбурові клітини, отримані з кісткового мозка, введені в ендометрій, просто введені в порожнину матки, попередньо роз'єднали синехії, які там були, і отримали вагітність. На картинках ви бачите ці синехії. Там повної облітерації порожнини матки не було. І вагітність отримана. І були роботи по лікуванню синдрому Ашермана, також на невеликому матеріалі, це, по-моєму, китайські роботи. І також показали, що ендометрій, об'єм ендометрія покращується при введенні стовбурових клітин. І така найбільша кількість пацієнтів була опублікована іспанською групою, як вже Марта говорила до того, що вони використовували так само стовбурові клітини з кісткового мозку, вводили пацієнтам з синдромом Ашермана із тонким ендометрієм іншої етіології. В цій групі була контрольна група, в цій групі покращувались показники товщини ендометрія, менше рецидивів синдрома Ашермана, тобто синехій, і описані вагітності після такого лікування. Джерелом стовбурових клітин може бути, власне, будь-яка тканина, де вони є, і в основному користуються кістковим мозком. Але є ще така тканина, яка в принципі легко доступна, жир. І вперше стовбурові клітини мезенхімальні виділені були з жира в 2001 році. І їх це приваблює тим, що це легше добути, не так важко переноситься пацієнтам, особливо тим, що йдуть на репродуктивні технології. І головне, що з невеликої кількості жира можна добути багато стовбурових клітин. Ми задумали таку от схему, це використання аутологічних стовбурових клітин, adipose-derived, отриманих з жиру. У пацієнтки забирається жир, виділяються стовбурові клітини, культивуються, бо нам треба їх розмножити, тобто культивуються в такому недиференційованому стані, потім заморожуються. Ми робимо далі з ними тести, перевіряємо їх, чи вони дійсно стовбурові. Це тести на диференціацію в різні тканини, і невральної ще, в мене просто немає картинки. Потім ми подивилися на початкових етапах, чи не впливає на це заморожування на якість стовбурових клітин. І побачили, що ні на морфологію не впливає до заморожування і після, ні на диференціацію, можливості диференціації, ні на експресію маркерів стовбурових клітин, ні навіть до 5-го пасажу, тобто скільки разів можна провести в цих середовищах, не змінюється каріатид, тобто не виникає анеуплеїдій. Тобто ми вирішили, і виживання клітин близько 96% після розморожування. Тому ми вирішили, що це безпечно для використання в клінічній практиці. І таку придумали схему. Ми не зовсім її придумали, ми використали схеми, які застосовувалися в ортопедії з стовбуровими клітинами, там були деякі дані про те, скільки вони тримаються, скільки тримається ефект. І тому ми в заступному циклі перед процедурою у всіх брали біопсію або гістероскопічну, або просто піпіль. І для того, щоб зрозуміти, кому допомагає, кому ні, і наскільки ушкоджений ендометрій. З агоністом ганелотропін-релізінг гормона проводили заступну терапію естрогенами, і там на 5-й, через деякий проміжок, від 5 до 10 днів повторювали 3 ін'єкції, робили цих стовбурових клітин. За одну ін'єкцію близько 1 мільйона клітин вводили. Далі ми чекали ефекта або в природних наступних циклах до 3 циклів, або в заступних, якщо це, наприклад, пацієнтка без цикла або анавуляторна. І спочатку ми планували всім робити контрольну біопсію, але потім від цього відмовились, тому що якщо гарний виростає ендометрій, то хочеться перенести зразу ембріони, а не відкладати це, тому що не у всіх пацієнтів ефект тримався довго. Як я вам сказала, ми робили гістологію до того, є дуже ушкоджений ендометрій, там, наприклад, тут тільки строма, а залоз немає, тут є трошечки залоз. Я зразу скажу, що оці пацієнти краще реагували, і в групі, де у нас не було росту ендометрія, в основному були отакі. Ми досліджували ще Кі67 маркер проліферації, естрогенові, прогестеронові рецептори, там ми не знайшли ніякої закономірності, хто відповідає, хто ні. Всього у нас за цей час було 25 пацієнток. На щастя, їх не так багато, тих пацієнтів. І це ті, хто вже пройшов всі інші, більш легкі способи адювантної терапії по покращенню ендометрія. І ми отримали це всі пацієнти з багаторазовими невдалими програмами, з гарними ембріонами. Я підкреслю, що тут не було такого, ембріонального фактора явного, принаймні. 12 вагітностей ми отримали, 9 живих, здорових народжених дітей. Зараз у нас вже їх більше, але це первинний результат, це просто перші вагітності після цих процедур. І 5 відсутність росту ендометрія і 8 був якийсь рост, але відсутність вагітності. Один випадок просто, це наша друга пацієнтка, 37 років було, коли вона до нас прийшла, непліддя 8 років, в неї була транслокація, каріатид був неправильний, і до нас в неї було 6 невдалих програм, у цих перших 3 програми про каріатид ніхто не знав, а Потім вона його зробила за своєю ініціативою, але далі вона відмовилась від ідеї досліджувати генетику ембріонів, а вирішила застосовувати донорські ацити, використовувати донорські ацити. І в них було ще 3 цикла на донорських ацитах, причому з переносом по 4 ембріона. З 2007 року вона лікувалася на дії на донорських ацитах. Гістологічно підтверджений атрофічний ендометрій, і на УЗІ він був до 5, в основному 3-4 мм. І 4 спроби ми намагались зробити перенос, нам не виростав зовсім ендометрій, і в 2 спробах ми все-таки ембріони перенесли, і на ендометрії там близько 5, але вагітності не було. І тоді ми вирішили застосувати її за тією схемою стовбурові клітини. В 2-му циклі, в природному, у неї ендометрій виріс до 7,5 мм, ми зробили перенос 2 ембріонів. Вводили ми стовбурові клітини, оці перші випадки, так, інтракавітарно, тобто в порожнину матки, провідником і такою голочкою для амніоцентезу ми використовували. Всі інші випадки, там після 4-ї, ми використовували трансміометральну голку для трансміометрального переносу. Субендометріально, в порожнину трошки, і субендометріально там нижня, передня і задня стіночки. Це її ендометрій, як він виглядав завжди раніше. Це на фолікулі власному, він став краще, більше. Ми перенесли 2 ембріони, отримали 2 плідних яйця, правда, одне потім редукувалося, саморедукція відбулася. Далі вагітність протікала без особливостей. І що цікаво, що ця пацієнтка до нас прийшла у 2014 році, і ендометрій у неї, не можна сказати, що він такий прям дуже гарний, але товщиною непоганий, товщиною там більше 7 мм. В неї зберігалися ще кріоембріони, ми перенесли знову 2 ембріони, отримали 2 вагітності і пологи, кесарський розтин у неї був. Тобто це вже у неї зберігся цей ефект, і зараз вона теж приходила до нас на контроль вже після цієї вагітності. Ендометрій у неї залишається гарним. Вона така унікальна, тому що в більшості він повертається до свого попереднього стану. І висновки такі, що лікування онтологічними отриманими з жиру стовбуровими клітинами приводить до збільшення товщини ендометрію і покращення гістологічної структури частини пацієнтів. Сподіваємося, що це лікування може бути застосовано у пацієнтів з багаторазовими недачними імплантаціями або монотонким атрофічним ендометрієм, синегіями. І зразу скажу, що важкі форми синдрому Ашерман з облітерацією порожнини, можливо, там треба якусь іншу тактику використовувати, воно не допомагає. А невеликі синегії, там невеличка облітерація, яка розділяється легко на гістероскопії, воно допомагає. І подальші дослідження потрібні для того, щоб зрозуміти, кому їх треба робити, якісь маркери, кому це допомагає, кому ні. Відбір пацієнтів важливо можливі ускладнення, протокол лікування. І зараз ми над цим працюємо, щоб використати якісь носії стовбурових клітин, щоб вони не так швидко там реалізувались, і не так швидко гинули. І ми думаємо про ці матрикси, scaffolds, гіалуронку, тобто намагаємося зрозуміти, як вони себе будуть вести. І такі напрямки, що робиться у світі. Ось стаття в Human Reproduction, трансплантація adipose-derived stem cells, жирові клітини, тобто стовбурові клітини отримані з жиру, на колагенових скафолдах, тобто на цих матриксах колагенових для передчасного виснаження яєчники. Це така цікава тема, власне, те, чим ми займалися тільки для ендометрії. Вони показали, що на колагенових скафолдах клітини реалізуються повільніше, менше гинуть і кращий ефект. Я вам говорила, що якщо гістологічно мало залоз, тобто, а тільки одна строма в атрофічному ендометрії, також це не допомагає лікуванню. І, скоріш за все, тому що мезенхімальні стовбурові клітини, вони відповідають за строму, за товщину, за строму, а функціонально такі ендометрії без залозу не можуть подолати цей фактор. І є робота така, це теж, по-моєму,